Hey everyone, so thanks for watching this video. I'm recording it because I wanted to kind of introduce a few ideas before I talk about this again in 2 weeks at our next class. And so again, I think it's going to be helpful if we can cover the content now and then actually talk about what this would look like at our next class. So um, basically, I want to give you a higher view from above in regards to different suicide event interventions that can be done to help someone in a suicidal crisis. And so the where I'd like to start actually is talking about a few of the ineffective approaches. So I'm going to get to what helps, but I think it actually helps to talk about what doesn't help, what doesn't seem to work. So the fact is there is a lot of shortcomings in the healthcare system in regards to how we deal with suicide. So the fact is the healthcare systems and individual providers routinely fail patients at risk of suicide. I know that sounds harsh, but I think that's the honest truth. So when you look at the research, nearly 50% of those who died by suicide saw a healthcare provider within 1 month prior to their death, and 80% had seen a healthcare provider professional within a year of their death. So the issue isn't necessarily that people who are suicidal are just not seeking out care. Um, I'd say that the failure to identify when a person is at high risk of suicide is the core of the problem. So in response to that, I think one thing that we need to consider is the possibility that routine screening for depression and for suicidal ideation, we'd like to see that happen in healthcare practice. If doctors, right, our primary care physicians, if they were routinely asking about depression and suicide, people would know, oh, there's some place I can go where I can get help, right? Because people don't routinely go see a psychologist. They don't routinely go to a mental health provider, but most people routinely see their physician at least maybe once a year, once every other year, and then when they're sick. If we changed what healthcare providers did so that they can ask these questions, um, the person, well, I think it does two things, right? You give them an opportunity to share about something they may be struggling with, but it also gives allows the person to know, like, there's professionals who take this seriously, who will help me with this, right? If you ask the question, that gives the message that it's treatable. And if it just gets ignored, I think it kind of contributes to this idea that there's nothing that anyone can do. So identification doesn't have to be precise, right? We don't have to get it right every single time. But if we're asking the question, if we're assessing, then we're at least introducing it. So broadly, we're helping more people than are being helped right now. Now, that's more in regards to the healthcare system broadly. But there's another issue, which is that we talked about this before, the 5150 holds. These are 72-hour holds that are done involuntarily, where a person is placed, basically their freedom is restricted even though they haven't committed a crime. And that's done when they're a danger to self, danger to others, or gravely disabled. So in regards to suicide, it's that question of, are they imminently suicidal? Are they a danger to themselves? Now, when I touched on this in the video in our guest lecture today, because it's Thursday that when I'm recording this, I asked about the issue of, like, schools that will have a policy in place. If a student talks about suicide, there's a sort of a policy that, okay, you need to put them on a 5150 hold, you need to call the PET team and basically send them for treatment at the hospital. And the assumption is that if you place them on a hold, it's going to relieve their suicidal desire. So, I mean, I don't think people would say this outright, but sometimes they just think, okay, I'll get them to the professionals. The professionals will figure this out and then do a great job, and this person will at least be well enough to sort of come back into society and be okay. But what really happens is that when they're on these holds, they will first off usually start off in a emergency room. They'll sit on a hospital bed for 8 to sometimes 24 hours. They'll usually have a person who will watch them one-to-one, and so they'll have a person basically sitting with them. They call them sitters sometimes, and then they will transfer them by an ambulance to a psychiatric facility. All right, and the clock is ticking. So this is an ER. They're usually not warmly received at the hospital. They're, sometimes they have a nice nurse, but sometimes not. And again, this could be up to a day. Then once they get to the psychiatric facility, they often receive 3 to 4 hours of group therapy to learn coping skills. They'll likely have a psychiatric consult where they'll identify some medications, get them started with them. They'll have 1 or maybe 2 sessions with a social worker who will develop a safety plan, and then will prepare them for discharge. And that's actually a good scenario. So sometimes I hear people and they don't even get that much. Now, that's not much. That's not going to be groundbreaking where they're suddenly going to not have desire for suicide. And if we consider that's the best case scenario, or I'll say maybe a fairly good scenario, I guess there could be better case scenarios, but that's a upper higher quality experience. Then we really need to appreciate that sometimes this is just not going to work. So oftentimes what they do at discharge, and hospitals are working to change this, patients will be given an appointment. They might be given a postcard or a printout that says, okay, here's your appointment. And it'll give a name of a therapist that they've never met and a time, and that's their appointment. And they are told, sometimes explained a little bit, kind of encouraged to go. Sometimes they're just, here it is, here's your appointment for your therapy session. And what they find is about half don't actually attend that. And so the appointment might be 1 to 3 weeks in advance. And we know that the risk of suicide is actually highest in the 3 days post-discharge. So one of the things Dr. Ortiz mentioned in her guest lecture is that sometimes suicide risk is actually elevated after they get discharged from the hospital. So sometimes actually a hospitalization can increase risk of suicide. I say that carefully because I certainly agree that there are times when hospitalization is necessary. You need to send people for good care. But I think right now there's a lot of things going wrong with the system, and you just have to sort of appreciate that. And I think part of the problem is sometimes there's an overemphasis of hospitalization as the way to go. But so another concern in terms of, and this is more specific to mental health professionals, is that the no suicide contracts fail. This is a failure. This is something that our field really needs to come to grips with, because these are still happening. And some people just haven't heard this, and we need to get the message out there that these don't work. So it's a no suicide contract is a contract It's written out where they will, sometimes the clinic will actually have a prepared version of it, and then they just write their name and sign it at the bottom. And it says the suicidal patient's not going to kill himself or herself within a period of time. So it might be the next 2 weeks or next month. The contract might require the client to contact the therapist or 911 if they want to act on suicidal urges. Okay, so what's the research say? There is no evidence that they're effective. One study found that 65% of suicide attempters at a psychiatric facility had signed a no suicide contract. So they had previously signed it, and they had attempted suicide. Again, that's 2/3 are given these and then still go on to attempt suicide. 40% of psychiatrists using a no suicide contract had a patient die by suicide. And what do we know about them? They often foster feelings of mistrust towards the therapist. I don't know if they really care about me, because they seem like they just are concerned about getting sued. And that's the message that you're putting out there with these no suicide contracts. So I can't say it strong enough, because you may be in a position where you're asked by a supervisor to do this. Now, I often will say, follow your supervisor. But this is a case where you need to go to your supervisor and say, I know you're asking me to do this, but and I know this is your license that I'm working under, but here's the research, and I don't feel comfortable doing this. And I would appeal if you're asked to do something like this, if you ever work as in a setting where you're being supervised by someone who wants you to do this. So I feel that strongly against it. And what we even find is that no suicide contracts, they don't even protect therapists from malpractice judgment. So you can be sued, but you can always be sued. That's not the issue. But you can be successfully sued. You can have a judgment against you that says, yes, you are responsible. You did not practice the best care when you did this. So again, when I heard this, when I was going through grad school, it was sort of mentioned, this doesn't work, but at least it's a risk management effort. But it's not. It doesn't protect you from being successfully sued. So you can still be liable for a client's suicide death if you do this, right? Because when you're suing, they're asking, is this the standard of care? Well, it is no longer the standard of care to do this. This is shown to not be helpful, and maybe even to be hurtful. And so saying that, oh, well, I did this, they're going to be like, well, so what? So what? You ask them to promise not to kill themselves, and because they wanted treatment, they signed it. So what? They were trying to get help, and you had them sign a contract. And so I think people would really look down on it. Okay, so all right, so those are some of the failures. And again, I want to highlight that the system is failing people who are suicidal. But there are so many good things, and I think things are changing where we are able to help people in a suicidal crisis. And so I want to talk about that. And I want to talk about two areas that you can help people. One is with clinical approaches. So these are types of therapy that work to help someone decrease their risk of suicide. And then the other one, I'm calling it adjunctive, and that just means an add-on to therapy. These are usually, you don't have to be a therapist to do these. So the clinical ones, you do have to be a therapist, but the adjunctive ones, you don't have to be. And so you can do them as a non-mental health professional, carefully, but you can, but they have effectiveness. They prevent people from killing themselves. All right, so I'm going to walk you through these. The three clinical interventions are dialectical behavioral therapy, CBT for suicide prevention, collaborative assessment and management of suicide, or CAMS. Then we'll also talk through these four: ASSIST, which is applied suicide intervention skills training, non-demand caring contacts, safety planning, and counseling for access to lethal means. Okay, so first off, in regards to intervention, historically, when people thought about suicide, they thought, okay, we need to go upstream, help them with their mental disorder, their depression, their anxiety, and that's going to have an effect downstream where the symptom of their desire for suicide is. So that is somewhat true, right? If you are able to resolve their depression or anxiety, you may help them with their desire for suicide. But it's more effective, is more helpful if you target the suicidal desire, the ideation, the behaviors. If you focus on them and say, okay, that's the goal, is the first goal, right? You don't want to give up on treating the depression, anxiety, but you say the first goal is, how do I help them with their depression and anxiety? That is more effective at helping people. And the newer models of care actually suggest that treatment and support of persons with suicide risk should also be carried out in the least restrictive setting. Well, what does that mean? So again, if we go back to this idea of, we should hospitalize it because we don't want them to kill themselves, and this is safer, this is safer. Well, that is overlooking the issue, which is that an involuntary hold is a significant intrusion on a person's life. It interrupts their work, their school, their social life. They have to explain it to other people. I mean, it is a big step, and there are situations where it's not necessary. So what these newer models are saying is that we want to help them in the setting that we want to be thoughtful about. What's the least restrictive setting that this person needs to be in? And oftentimes that's outpatient. They don't have to be hospitalized. They don't have to be at a residential treatment. They can actually get treatment and continue on with some of the things that they're doing in the rest of their life. So there's actually a continuum from hospitalization. Then they have partial hospitalization, intensive outpatient, and then they have outpatient treatment, group therapy, things like that. And so most of the time, most people at risk of suicide need outpatient treatment. And again, sometimes we're over relying on, let's refer them out, send them to inpatient treatment. And I think that's burdening our mental health system. And it's also not in the best interest of our patients, of the clients that we work with. Okay, so let me give you an overview of DBT. I'll talk about this further in 2 weeks, but it's got 4 components. It's a skills training group. So it's a skills training group, which means that you are teaching people, you're teaching your clients social skills and emotional regulation skills and coping skills. And so it's a group. You can actually teach that in a group setting. And that happens for 24 weeks, so about half a year, 6 months. Then there's individual treatment once a week, and you do that at the same time of the skills group. So the skills group might be, I forget how long it is, but it might be like an hour and a half, and then a 1 hour or 50-minute individual session with the therapist. And then on an as-needed basis, you would have phone coaching. The client would request that. And then you have consultation team meetings. Now, this is not where the individual, the client is involved at all. They're not present. This is where the therapists who so they think of it as a team-based approach to treating. They'll come together and consult with each other to try to get input and ideas about how to help this person. And when it's done in this format, DBT is effective in reducing suicidal behavior. So Lehmann, who of course we mentioned before, Marsha Lehmann, she was the one that had her theory was the reasons for living. Again, she's a well-known, prominent theorist and researcher. And what she found is that if you compare 1 year of DBT with women with borderline personality disorder, those are the acronyms there, and 2 or more suicide attempts, and or self-injuries in the past 5 years. And you can, okay, sorry. If you compare that to non-behavioral community treatment by experts, sorry, that's a long sentence. If you compare DBT to non-behavioral community treatment by experts, again, experts, people that know what this, how to treat suicidal ideation and behaviors, those receiving DBT were significantly less likely to drop out of treatment, attempt suicide, visit psychiatric emergency rooms, and experience psychiatric hospitalization. So there was a significant difference that they saw between experts, right, psychologists who were trained in suicide prevention, and these groups that did DBT. So it works. And so it's one of the clinical tools that you could potentially, if you're in graduate school, you can seek out more training on DBT to become familiar with it. Again, it's a kind of hard to do this format if you're in a private practice, but if you're in a community-based setting, you could set up a group and a means of doing this so that you can, again, help people with borderline personality disorder. Again, this disorder that's highly related to suicidality, and work with these people with a lot of risk, 2 or more suicide attempts in the past 5 years, and you can actually help them have better outcomes than experts with suicidal prevention training. Again, this is just a sign that, like, this is a really effective treatment. All right, the second one is CBT for suicide prevention. So this is CBT, cognitive behavioral therapy, and it's a specific adaptation. It's actually a manualized protocol. Basically, you have session 1, session 2, 3, 4, and they say exactly, okay, this is what you're going to talk about in session 3. This is what you're going to talk about in session 4, and it involves cognitive restructuring strategies like identifying and evaluating automatic thoughts. That's just basics from cognitive therapy. But you also teach them emotion regulation strategies, action urges and choices, the emotions thermometer, index cue cards. I don't know exactly what that is. Mindfulness, opposite action, and distress tolerance. And so they borrowed some things from DBT, and then finally they have other CBT strategies such as behavioral activation and problem solving strategies. Okay, you probably don't know what more than half of those things are. That's okay. What do we know? We know it works. This is an effective evidence-based approach to helping people with suicidality. And one more thing, among adolescents, oftentimes they do family interventions to address some of the problematic relationships, abuse, family dysfunctions that might be present, school issues, and so they try to work on the whole person. Okay, and again, this is effective in reductions in attempts, in suicide attempts, and reductions in suicidal ideation. Now, the third and final clinical intervention that works, that is evidence-based, is CAMS. Again, collaborative assessment and management of suicidality. developer of this was Jobs, Jobes. And so CAMS is shown to effectively address patient-defined suicidal drivers. So this is what their sort of theoretical framework is, that there's drivers of suicidality. It's the pain, the agitation, the self-hate, and the hopelessness. And there's a fifth one, and I forget what the fifth one is. But these are the drivers of suicidal ideation. And what they try to do is find, okay, why are you in pain? Why are you hopeless? Why are you agitated? And they look for those causes of those emotional affective states. And they say, okay, let's target whatever's driving those things. And if we can target those things, that hopelessness, oh, sorry, it's right here, psychological pain, stress, that's the one I missed, stress, agitation, hopelessness, and self-hate. And if you can target that, then you can actually reduce the intensity of their suicidal ideation. And it's really interesting, the way they think about suicide in CAMS is that suicidal thinking is a sensible, though concerning, response to psychological pain and suffering. So this is actually what I tend to use when I'm working with the suicidal client, is that one of the things I say is that, I'm not going to take suicide off the table. I know, and they know, that suicide is an option for them, right? If I claim otherwise, if I say you can't do this, well, they know and I know that they can, because I don't have control over every moment of their life. So if we acknowledge that, then we could potentially appeal to their agency, their free will, and say, so this is going to be up to you. If you want to work on this, I can help you, and I can help you find other solutions to these problems. The reason why you're thinking of suicide, it's a sensible response to psychological pain. It's a sensible response to stress or agitation or hopelessness or self-hate. But what I want to help you do is find another solution that doesn't involve killing yourself. And so that would be how I would frame it. Okay, now there's a few adjunctive interventions. These are other things that we can do, and actually you can do. For the most part. Now, applied suicide intervention, if some of you have been in military settings, the military uses this, and basically, as far as I know, does this training with all soldiers. So if you're enlisted, you would do this training. So it's a 2-day training for all caregiver groups. It's a non-clinical intervention. This is actually what the Suicide Prevention Lifeline uses. And the participants learn, so this is just the big picture things, how to identify persons with thoughts of suicide. So what are the warning signs? How to identify if they're thinking about suicide. How they develop a shared understanding of reasons for dying and reasons for living. They develop a safety plan based upon a review of risk, and they follow up as needed, and they become involved in suicide safer community networks. Now, a lot of that you're already going to be familiar with from this class, right? You know the warning signs, you know about reasons for living, reasons for dying, you know how to do a safety plan. And we haven't really talked about suicide safer community networks, but we've done a lot of this. So you're actually most of the way there, but you have to do this training in order to get certified with it. So if you're interested in learning it, you can, they do offer it. I think it's usually for a cost, but the cost isn't too bad. So this is something you could look into. The second adjunctive intervention is non-demand caring contacts. Now, this is a fancy way of saying, give them a call, send them an email, send them a postcard, a text, anything after treatment is over. Follow up. So it's a non-demand caring contact. You're not asking them to do anything. You're just saying, oh, hey, just want to see how you're doing. Hopefully you're doing well. We're thinking about you, and let us know if there's anything we can do to support you. So this isn't, again, it's not an intervention, it's not treatment, and it sounds extremely simple, but the research shows that that small act can be effective at reducing suicide risk. So if there's a psychiatric hospital that discharges patients, they can actually set up a automated system and where they send them a text, 3 days after they discharged. And you can actually set it up so it's not even, nobody even has to write the text or do much work. It can be set up automatically, and even then it still reduces risk. And the reality is, in complex healthcare organizations where there's a lot of clients, a lot of incoming intakes and discharges, it's very easy to forget to follow up with people. But it shouldn't be that way. The system, the best way to care for people is actually to follow up with them. So I think this is something, again, you don't have to be a professional to do. And again, it doesn't have to be automated. You can do this as a personal basis. In fact, it's probably better if it is. But yeah, there is a role that you could play to just check in with people and see how they're doing. All right, the third one, you do know, safety planning. I won't go over this too much, but it works. And again, you don't have to be a mental health professional to do this. So you can use it within clinical care. So you can use it as a therapist. In fact, I do this with my clients, help them come up with a safety plan. But again, you got the training. If you are working with someone who is having thoughts of suicide, you can do this with them. And I think they could potentially see it as very caring if you were to offer to do that. Again, you might not feel comfortable, and I would certainly encourage you guys to refer and consult with someone if you're working with someone who is thinking about suicide. But again, one of the key things about suicide prevention is just having people that care about you. And if you just make the effort, that's going to be meaningful to people, and it's going to help. So, and you want to do that collaborative. You don't tell them, here's what you should do. You ask them, what do you think you should do? Who can you turn to? How do you think you can cope best? And again, it lifts up the person to say, this is yours. This is up to you. And it keeps the power in their control. And this fourth one, this one you have learned as well. Counseling for access to lethal means, or just generally reducing access to lethal means. So one of the things that people sometimes fail to do when they have someone who's suicidal, it's because it feels uncomfortable to ask, but you really do need to discuss lethal means that they have available to them. Now, oftentimes the barrier to this is the therapist or the person who's trying to be a helper says, well, I can't, if you just look around, there's things that I could potentially, that anyone could use to kill themselves. And how can I remove all of it? Well, you don't have to remove all of it. You really want to remove the most lethal means. And the most lethal are always firearms. So that's always the case. Make sure, even if they're denying, oh, I'd never use a firearm, make sure it's not available to them. And then anything else that they're claiming as like, oh, I keep thinking about this thing. If at all possible, get rid of it. So I've had clients that had to get rid of a toaster because they thought about using that to take their own life. And so you want to arrange for the removal or reduction of lethal means as much as feasible. And so the toaster was a hard thing, but it just became apparent that one of my clients just kept thinking about it, and it just had to go. And so, people can live without a toaster. So again, this is a conversation sometimes people, even therapists, struggle to have, but it's really important. All right, so that's it. And so hopefully this will give you a little bit more of a framework for some of the ways that you can help someone. We'll return to this. We'll talk about it a little bit more slowly, unpack it some more, but I wanted to at least, not have to rush. So that's it. I'll stop there.